All right, good morning, everybody. Welcome to Pediatric Grand Rounds. I know a bunch of you are online, and thank you for being here, and those of you who are here in person, thanks. I'm so excited to introduce Dr. Deb Liptzin, who is a professor of pediatrics at the University of Washington School of Medicine and in pulmonology here at Seattle Children's. She comes to us after residency in Pittsburgh, fellowship in Colorado, and faculty positions in both Colorado and Montana. And she came to join us here at Seattle Children's in October of 2023. We're so excited to have Dr. Liptzin teach us today. Welcome.
Good morning. Thank you guys so much for having me here. I'm excited to give this talk. So I will be talking about chronic cough controversies. My disclosures, sadly, I have none currently. I was previously part of the Idea States Pediatric Clinical Trials Network, which we'll talk about. I'm employed by the University of Washington School of Medicine and Children's University Medical Group. I write chapters for Nelson's Pediatrics and Kending's Disorders of the Respiratory Tract in Children. And several of slides are borrowed from my colleagues in pulmonary. These pictures are just to remind me that this is really the tip of the iceberg, and there are so many rabbit holes that you can go down on with this topic. And I've gone down a few of them, but certainly there are way more that one could explore. So the Idea States Pediatric Clinical Trials Network is a program supported by the NIH. It was an institutional development award program authorized in 1993, and its purpose was to broaden the geographic distribution of NIH funding for research by enhancing the competitiveness for research funding of institutions located in states in which the aggregate success rate for grant applications is low. So the ISPCTN, the Pediatric Clinical Trials Network arm, their goal was to provide an opportunity for children in rural and medically underserved locations to participate in state-of-the-art clinical trials, enhance pediatric clinical trial capacity, and to facilitate implementation of well-designed clinical trials in pediatric populations. So these are the IDEA states and Puerto Rico. And you can see Washington is not one of them, but many of our WWAMI states are. So Montana, Idaho, Wyoming, and Alaska. So let's move into why I care about chronic cough. So this is where this all started. So in March of 2021, my family and I moved from Colorado to Missoula, Montana. I became the second pediatric pulmonologist in the state of Montana, covering the western part of the state, taking over for Paul Smith, who was retiring to focus more on research. This is where we lived in our Airstream for the first 20 months that we were there while we were trying to build a house. And this was our property, and the hospital was about a 12-minute walk kind of right through these trees. And this is the day we showed up. It was snowing. So I started clinic there, and all of a sudden I had all of these really anxious moms calling for antibiotics because their kids are coughing, and Dr. Smith always prescribes antibiotics when Johnny starts coughing. And then I had all these pediatricians calling and saying they're treating a kid for protracted bacterial bronchitis, but they're still coughing, and what should they do now? So this was all very new to me. So I knew about protracted bacterial bronchitis, but I had not had this many patients treated for it before. And so this all led to an exploration of chronic cough in children. So first of all, since it's the Olympics, let's talk about sports for a little bit. So arm wrestling dates back to 2000 BCE, and the rules and regulations are set forth by the World Arm Wrestling Foundation. So on the one hand, we've got antimicrobial stewardship, and then on the other hand, we've got these distinct populations in Alaska and Australia, and there's a conflict between these two, and we're going to discuss that. So all of this led to us publishing this paper, Controversies in Antibiotic Use for Chronic Wet Cough in Children, and we'll talk a little bit more about that. So this is me. This is Dr. Carlson. He's allergy immunology in Louisiana. Paul Smith was the pulmonologist before me in Montana and part of the ISPCTN. Roz Singleton is in Alaska, and these guys are infectious disease docs. So we had a very diverse group putting their heads together about this, and we put together an NIH grant about it. So let's talk about chronic cough. It is a huge problem. So almost 30 million physician visits a year in the US, causes a lot of parental anxiety. Quality of life scores are lower in people who have chronic cough, and it's a significant healthcare burden. So 80% of the patients in this study had at least 5 physician visits, 53% had more than 10 visits, 76% saw 3 different kinds of physicians, 30% had seen 4 or more types of physicians, and about a third were referred to a respiratory specialist. Expected cough duration. So I thought this publication was fascinating when it came out while I was in fellowship. So acute cough, and they had definitions for what all of these mean, but acute cough resolves in 10 days in 50% of children and 25 days in 90% of children. Bronchiolitis resolves in 13 days in 50% of children and 21 days in 90% of children. Non-specific URIs resolve in 10 days in 50% of children and 15 days in 90% of children. So kids who are in daycare really might be coughing all the time. Just polling the room, how many of you have young children or had young children at one point? Were they ever in daycare? How many coughed more days than they didn't? Yeah, so this is Eli. He's now 5. He's going to be starting kindergarten. This is when he had perioral and acral cyanosis when he was in daycare. And he literally, we put him into daycare at about 4 months of age, and then we went on a 3-week vacation when he was about 15 months of age. And I distinctly remember 2 weeks into our vacation thinking, I haven't heard him cough. I think that's the first time I haven't heard him cough in I don't know how long. And so I have lived this as well. So I'm very familiar with the young children who cough. It's a huge problem in terms of my practice. I hear from parents all the time, my kid is coughing all night. They can't sleep. My kid's poor little body, what's going to happen to them? I can't sleep. They cough until they puke. Then I have to change the sheets and do laundry. Is the cough causing long-term damage? And then the biggest question that I always love getting is, should I pull them out of daycare and do I need to quit my job? How long is considered chronic in pediatrics? Well, it varies from study to study. Typically, greater than 4 weeks for kids under 14 years of age is considered chronic cough. I would also like to point out that, at least in my experience, RSV in 2022 to 2023 led to a cough that lasted for 8 weeks. And so you can just get a chronic cough from a virus. So I dug into the literature. There are many Cochrane reviews about chronic cough. So antibiotics for prolonged wet cough in children, clinical pathways for chronic cough in children, inhaled corticosteroids for subacute cough in children, and inhaled chromones for prolonged nonspecific cough in children. One of the things that I would like to point out about all of the Cochrane reviews on chronic cough is that you see the same author in all of them. So Dr. Chang is I think she's actually a psychologist, but she is in Australia and has dedicated her career to chronic wet cough in children in Australia. So we're going to talk about 2 contrasting studies of chronic cough. So here's study number 1. This takes place in Australia. They looked at 108 children with chronic cough. They were under 18 years of age, and the median age was 2.6 years. Kids were coughing for at least 3 weeks, and most of them, 89%, had a wet cough. These were the results that they found of the study in terms of what were the etiologies of the chronic cough. So 40% had protracted bacterial bronchitis, which we'll come back to, and less than 10% had asthma. Now, in our prevalence studies in the US, we find that about 12% of kids have asthma. And so the prevalence of asthma in this cohort of kids with chronic cough was lower than the US prevalence. The other thing I would like to point out is the second most popular category, so protracted bacterial bronchitis was 40%, and then natural resolution, or the cough goes away on its own, was in more than 20% of the kids as well. This is a second study looking at chronic cough in New Orleans, and they looked at 40 children who were coughing for at least 8 weeks. The mean age was 7.8 years, and wet cough did not appear in the article, so they did not differentiate between the two. And every patient in this study did the following workup as appropriate for age. So chest radiograph, pulmonary function tests, methacholine challenge, bronchoscopy, sweat test, pH probe, allergy skin tests, and immune screening. Some of them had further studies, including tuberculin skin tests and laryngoscopy, alpha-1 antitrypsin, response to immunizations, EGDs, video fluoroscopic swallow studies. They found that infection was in 5% of the kids. So in the previous study, it was 40%. In this one, it is 5%. And what they found much more commonly was some combination of asthma, allergy, reflux. All right, so we're going to talk about Team PBB, so Australia and Alaska. Many of you know this guy. This is Dr. Greg Redding. He is pictured here a few years ago in Alaska next to a water fountain where it says no spitting. And he uses this slide in his talks because people there just spit up mucus all the time, which we will talk about a little bit more. And this is not something I have seen at water fountains in the lower 48 ever. So protracted bacterial bronchitis. Protracted bacterial bronchitis is a common cause of chronic wet cough in children. There's a bacterial infection in the airways that causes an increase of mucus and continual cough. The chronic cough is one that lasts for more than 4 weeks. It can cause missed days of school, reduced sleep, and recurrent need for medications. Cough is common with acute respiratory infections caused by viruses. One should suspect PBB if the cough lasts for more than 4 weeks. Now, I don't know about you guys, but I was kind of taught in my pediatric training that kids don't get bronchitis and kids don't get sinusitis. And so when you hear about PBB, it feels very antithetical to everything that you're taught. But in certain populations, this is something that we certainly see. And in pulmonary clinic, and especially in aerodigestive clinic, this is something that we do see. So the definitions of protracted bacterial bronchitis, there is a clinical definition. So this is a wet cough of at least 4 weeks of duration, gets better with prolonged antibiotic use of 10 to 28 days, but recurs with less than 7 days of antibiotics. Doesn't get better with bronchodilators, and there's no other obvious underlying etiology, for example, cystic fibrosis. Laboratory PBB, which would be more of the gold standard, is getting a bronchoalveolar lavage fluid that shows a bacterial pathogen. Recurrent PBB is at least 3 episodes a year despite treatment for each episode, and 40% of the kids with PBB will have recurrence at some point. So PBB is a prolonged wet cough, but not all prolonged wet cough is PBB, and I think that is a very important distinction to make. So when you look at prolonged wet cough in kids, this is from this Cochrane review, they were looking at greater than 10 days of wet cough. They included 3 randomized control trials with 190 children total, aged 21 months to 6 years, and they found that antibiotics worked, that they treated with amoxiclav or erythromycin for 7 or 14 days. Adverse events were similar between treatment and control, and the quality of evidence was moderate. There are some physiologic contributors to PBB, so malacia or collapse and floppiness of the airways. It leads to your inability to clear your mucus, and so your mucus stays down in your lower airways, and then the bacteria get in there and they have a little happy party. And so typically what we'll see in kids with malacia is that they get a virus and then they just develop this chronic wet cough that lingers and lingers and lingers. So in 98 children with airway malacia on bronchoscopy, 38% had recurrent respiratory infections, 18% had persistent coughing. In 70 children with bronchoalveolar lavage growing bacteria, 74% had airway malacia. And this is just showing you what this is a normal airway, so normal C-shaped cartilage. And then this is airway malacia with an airway. The trachea is just that little black spot right there. So really hard to clear mucus. And when we're doing a bronchoscopy, we can watch and we can see kids coughing and see their airways pancaking. We don't have a denominator, though, because we're not doing bronchoscopies on kids who are otherwise healthy. And so in terms of how and our grading of tracheomalacia, I would like to acknowledge is challenging because it depends on the plane of anesthesia. Are they coughing? Are they not coughing? And so our ability to diagnose it is a little loosey-goosey. Let's go back to Team PBB. So respiratory morbidity in Alaskan children. So back in the fall of 1997, they looked at 377 Alaska Native American Indian middle school kids in the YK Delta. 40% of them reported chronic respiratory symptoms, and 30% of them spit up mucus. And I think if you ask 100 kids in the suburban Seattle area, do you cough up mucus? They would probably almost all look at you really weirdly. If they had cystic fibrosis and weren't on modulator therapy, then maybe they would answer yes, but otherwise we really don't see kids that just say, oh yeah, I spit up mucus every day. This population is very different, and a lot of you know this better than me because you've done rotations up in Alaska, but it is a huge geographic area with 25,000 people. 5,600 live in Bethel. There's lots of indoor air pollution, including crowding, tobacco, wood-burning stoves. On the plus side, they don't have as many allergens or vehicle emissions, so they do have that. And they also compared these kids to the 89 non-Alaska Native, non-American Indian kids who had fewer chronic respiratory symptoms, so 35% chronic respiratory symptoms, and way fewer that spit up mucus. So only 7% of that population reported spitting up mucus. So why do we care so much about PBB? Well, it can lead to bronchiectasis, which can be permanent scarring in the lungs, which leads to a whole host of other issues. So in 161 children, 43% had recurrent PBB, and of those, a number of them underwent CT scan, and 13 out of the 23 had bronchiectasis. And so CT scan, it's like we're standing at the feet looking at the head. This is right side, this is left side. Black is air, white is bone, and gray is something in between. Here is the spine, here's the airway, and then you can see here we've got all of these really dilated airways. And we usually judge it based on the airway size compared to the adjacent blood vessel. So if the blood vessel is smaller than the airway, then that's considered bronchiectasis. There are some nuances to that as well, including at altitude and how it's defined and dehydration. But generally, if your airway is bigger than the vessel, that's bronchiectasis. There's this progression, there can be a progression, it is not absolute, from protracted bacterial bronchitis to chronic suppurative lung disease to bronchiectasis, and bronchiectasis can be reversible at first and then becomes irreversible. So in the YK Delta in Alaska, 14 to 20 per 1,000 people have bronchiectasis. Compare that to the US general population, and it's 4.2 per 100,000. So let's look at the actual guidelines, because this is where I got hung up a little bit. So the CHEST guideline and expert panel report said that for children aged up to and including 14 years of age with chronic cough, defined as at least 4 weeks duration, wet or productive cough unrelated to an underlying disease and without any specific cough pointers, so coughing with feeding, digital clubbing, we recommend that children receive 2 weeks of antibiotics targeted to common respiratory bacteria like strep pneumo, H. flu, MCAT, and local antibiotic sensitivities. The British Thoracic Society cough guideline says that children with PBB should be treated with chest physiotherapy and a prolonged course of 4 to 6 weeks of appropriate antibiotics. Australian cough guidelines for PBB, medium-term antibiotic treatment of 2 to 6 weeks should lead to complete resolution. Antibiotic selection is location-specific based on susceptibility. So in Alaska, they use amoxiclav high dose, so 40 to 50 milligrams per kilo BID. In the rest of the WAMI region, it would be regular dose because we don't have the same susceptibilities as they do. Let's talk about antibiotics and some other disease processes. So I have two of my colleagues who know a lot more about cystic fibrosis than I do, but kids with CF get a lot of antibiotics. And as Dr. Kogan says, antibiotics can be poison. So there are 312 children with cystic fibrosis aged 6 to 17 years. They received 763 oral antibiotics in 1 year. Median of 2 courses per year, but a range of 1 to 10. So some kids got 10 rounds of antibiotics a year, and typically those are prolonged courses, so at least 10 days. When these kids are coughing for more than 2 to 5 days, they typically will receive outpatient antibiotics. Cystic fibrosis inpatient pulmonary exacerbation treatment with at least 1 antibiotic for a minimum of 10 to 14 days is typical. We use a lot of aminoglycosides in this population, which leads to hearing loss and kidney damage. What we've been finding recently in cystic fibrosis is that longer antibiotic duration is not necessarily better, so that 21 days was no better than 14 days, and 14 days was no better than 10 days. So we've been shortening our antibiotic courses in cystic fibrosis. And so here's just showing the difference between 14 days and 10 days, and then 21 days and 14 days. What about in garden variety pneumonia with normal innate ciliary clearance? For non-severe community-acquired pneumonia, 5 days is just as good as 10 days. 3 days is just as good as 5 days. And for the trainees in the room, this probably is very normal to you. For those of us who trained with 10 days for pneumonia, it feels very icky to do it for shorter. It's scary to change your practice pattern when you've been doing it one way for so long. I would say the same thing with the implementation of the SMART approach to asthma, that we have done inhaled corticosteroid with albuterol quick relief for so long, it is hard to transition the way that you practice. Some people will say, my patients are different, and sometimes they really are, but sometimes maybe they're not, and that 5 days can be just as good as 10. The World Health Organization recommends 5 days of amoxicillin for pneumonia. So we're using less and less antibiotics, including for acute otitis media, cystic fibrosis, pneumonia. Let's dig into what we propose to do. So we were charged as part of the ISPCTN with figuring out some kind of guideline where there was still controversy or something that needed to be further fleshed out. And so we took this guideline and said, well, let's do this study here in our network, because all of the other studies had been done in Australia in a certain population. And so we wanted to do it in our population. So our specific aim 1 was to determine if a significantly higher percentage of children with chronic wet cough have cough resolution when treated with amoxiclav for 2 weeks compared to children given placebo. Specific aim 2 was to determine the proportion of children who have not had cough resolution after 2 weeks of antibiotic who resolve after an additional 2 weeks of antibiotic. Specific aim 3 was to evaluate quality of life scores between the placebo and the treatment group. Specific aim 4 was to determine time to cough recurrence over a 6-month follow-up period between those treated for 2 versus 4 weeks of antibiotics. For those who have written grants, you can imagine that for each of these questions, we had a lot of fun debating how long we were going to do everything for. Are we going to treat for 2 weeks? Are we going to treat for 10 days? Are we going to treat for 21 days? How long do we want the follow-up to be? Should we not do a follow-up, or should we do a follow-up? So we submitted it, and it was really exciting. Yay! And this is just a moment to remind everybody that celebrate the wins that you get. So you submit a proposal, celebrate that. You submit a manuscript, celebrate that too. And it's out of your hands and you can't worry about it anymore. So the feedback we got was fascinating. So some people said, I have concerns for prolonged antibiotic use and altering the microbiome. Is there evidence in young children that this prolonged use of antibiotics could impact health outcomes, such as obesity, asthma, diabetes, etc., later in life? And then, if these are the guidelines, is it ethical to delay treatment of children assigned to placebo for 2 weeks? The Alaska site didn't feel like they could ethically participate because it would be going against what their standard of care is. So, where do you go from there? Comes back to this question of antimicrobial stewardship and protracted bacterial bronchitis. So you've got the risk of overtreatment, antimicrobial resistance, allergies, adverse effects, altered microbiome. And every additional day with antibiotics, there's a 7% chance of an adverse effect. On the other hand, you've got the risk of undertreatment and ultimately airway scarring. So we called out the issue. We put together we put together the grant. We got feedback, didn't get the grant funded because people were too divided on it, that it's unethical to do this, or it's unethical to treat with these antibiotics, or it's unethical to not treat with these antibiotics. And so I think the question is still out there. And so in reaction to the feedback that we got, we published this manuscript describing this exact phenomenon. So here are my thoughts about it. Clearly, there is a disconnect. You want to make sure that you can apply results from a study to your specific population. More studies are clearly needed. We obviously need better biomarkers. I think that cough sensors have a possible amazing role in this realm, in that they can detect. Parents come in and say, my kid is coughing all day and all night, and you have an hour-long visit and the kid doesn't cough once during the visit, and it's really hard to know what to do with that. And so cough sensors give you an objective measure. They also some of them have the ability to measure what kind of sound wave the cough is producing, and so can you differentiate between different coughs? So a kid who's aspirating, a kid who has reflux, a kid with asthma, a kid with protracted bacterial bronchitis. And would this be a way to help differentiate between all of these? And then there are risk factors. So race, ethnicity, running water, indoor irritants. These are huge issues in some of our populations and do not necessarily apply to other populations as well. So these are some of the apps from different cough sensors. And then this is looking at the socio-demographic characteristics of the Alaskan Native children. So looking at the study homes versus U.S. homes in general. So you can see that there are more occupants per home, almost more than double. The homes are smaller. You have way more homes with more than one person per room. Way more homes with a primary wood stove for heating. Way more homes with a smoker, and way more with no running water. And one of the reasons no running water matters is that with a lack of indoor plumbing, sometimes people will burn a variety of things to mask the smell of the lack of indoor plumbing. So here's one of my favorite chronic cough stories. So a 14-year-old boy came to see me in clinic with a chronic cough. I said, when did your cough start? He said, well, I was eating lunch at school 2 months ago, and I bit my retainer, and I've been coughing ever since. His mom said, you did not choke on your retainer. And he said, Mom, I did. And so I listened to him, and this is one of the rare times where the exam 100% changed my plan. And he had a differential lung exam. Couldn't hear as well on one side versus the other. I called ENT and said, hey, I think this kid has a retainer in his airway, and they pulled it out. And I never saw him again because presumably it was better. So the lesson here is always remember to take out your retainer and do not put it in a napkin. I was at Camp Quarry volunteering earlier this summer, and we got a call. Dr. Deb, are you still in the cafeteria? One of the kids threw out their retainer. And so we got to go dumpster diving for it, which was awesome. So do not keep your retainer in your mouth when you eat, and put it somewhere safe that doesn't end up in the trash. So this is my second favorite chronic cough story. So it was, again, a 14-year-old girl. I will say that usually the chronic cough kids are in the 1 to 5 range, and so maybe this is why they're my favorites, is because they're the anomalies. But 14-year-old girl with chronic cough and recurrent pneumonias. All of her pneumonias were in the right lower lobe. This is a reminder, never trust anyone and always view the images yourself. Because a lot of times it's not actually a true pneumonia, especially if it's read by an outside adult radiologist. She had a normal workup, including spirometry, sweat test, CF genotype, nasal nitric, rheumatology workup, immunodeficiency workup, and fungal and TB testing. So here is her CT scan, initial CT scan. Let's see. So this is the AB normal part. So chronic right lower lobe post-obstructive airspace disease, along with subcarinal and right hilar adenopathy and narrowing of the airway to the right lower lobe. And we did a bronchoscopy. So this is her carina. This is her right main stem, and it is full of pus, like just pus. They couldn't see anything beyond the pus. And so much pus that the senior attending I was working with at the time, I was in fellowship, said, I have never seen that many white blood cells in a bronchoscopy. So there were 237,390,000 white blood cells, which were almost exclusively neutrophils. So we did what any good pulmonologist will do, and we did a lot of airway clearance and antibiotics, and then we did a repeat CT scan. And you can see all the mucus is gone, so we fixed that. Yay, antibiotics and airway clearance. But she's left with this horrible bronchiectatic area. Because she got another pneumonia following this, she ended up getting that area of her lung resected. And so this is her lung, this is the bronchiectatic airway, and this is her bronchiectatic airway. It kind of looks like guts, if you ask me. It's kind of gross. And what you will notice is there's something right here. And not a retainer, not a retainer. It said, ladies flip-flop, size 5 to 6. Whoa. And they said, oh yeah, I had those flip-flops like 3 years ago. Mom said, she used to chew on everything. I'd also like to just point out these images are from Megan Dishop, who was a phenomenal pediatric lung pathologist who sadly died recently, about a year ago. And she was phenomenal and taught me most of what I know about pediatric lung pathology. She was so tickled about this kid and this case. And the rabbit hole she went down was looking up the flip-flops and finding the characters that would have been on them. And after we resected her lung, she did much better and she didn't have any more pneumonias. So I think the take-home point is that not all coughs are the same. Everyone is a little different. My kid coughed for like 14 months. So there is debate about like, well, what does this mean if you have recurrent respiratory infections over and over again in your early years? What will that mean for you and your lung function? And I think there is the scientific big picture question, and then there's the practical question about what are parents going to do about that? And comes back to the questions that we get asked in clinic all the time, like, do I need to quit my job? Is this going to cause long-term damage? Are they going to have asthma? Do I need to hire a nanny? All of those things. And those are the really hard questions that we get in clinic. All right, so thank you very much. These are slides from Dr. Kogan. My mom said you should just go ahead and give me an antibiotic now because you know she'll just call and complain until you give in. And that fever is not necessarily a sign of antibiotic deficiency.
Thank you so much for that fantastic talk and also helping us understand the kind of opposing viewpoints and ethical dilemmas about this area of work. And I'm a general pediatrician and just had a patient that I was having to grapple with whether or not to treat for protracted bacterial bronchitis. And up to date's recommendations, my question's around kind of where do you land on the recommendations, since we would love to have your study be funded and figure out what we actually need to do. But as I recall, it was closer to the 4-week mark to start with the broad spectrum antibiotics with, and I went with Augmentin. But what is your take on that? Should we actually start with the 2 weeks and then see if beyond that if they need another 2 weeks, or what? We're still grappling with that dilemma in practice. So would love your thoughts.
1,000%. So the population I typically see it in is the aerodigestive population, where they have a chronic cough. We're doing triple scopes on them, so pulmonary bronchoscopy, ENT, MLB, and EGD. And when we see a lot of bacteria and a lot of white blood cells on the bronchoalveolar lavage, we will typically treat. And I usually treat for 10 days, and it would be interesting to hear what my counterparts do, partly because that should be sufficient in most kids. And that's how long a bottle of amoxiclav lasts for, and so that sounds way easier. 14 days means having to go pick up a second bottle or reconstitute it at home, and so I don't. And then, I haven't had a lot of kids where I feel like I need to do a second course, but that is typically what we'll do. What we'll say is, like, if you're not better, let us know, and we might need to do it for longer. I would say those are really rare, though. Really rare. So I don't know. I struggle with it, too.
The guidelines on the up-to-date also could be updated.
Well, I would be curious to see who wrote the guidelines. So the question was, what do you do about, how do you interpret the guidelines when they're on up-to-date? Because that's where we go for all of our medical information. And I would be curious to see who wrote them. Yeah.
Very likely. Thank you.
Deb, I was wondering if you had any plans to maybe revise and resubmit that grant. It's such an important topic, and any chance to resubmit that grant, change it in some way so that you could get around these ethical concerns and get it funded?
Thank you for that question. When I left Montana, I left the ISPCTN, and so I don't have my whole network of people anymore. And so I would be happy to, if anyone wants to work on that with me.
Please reach out if you're available.
But I agree. I think it's a really interesting question, especially with all the guidelines based on studies out of Australia, that it just makes me feel really uncomfortable with the guidelines.
I want to ask a question about the flip-flop case. So I work in the ER. We often will start with an x-ray. On the x-ray for that patient, was there something that would have made the provider think of this? Or would you need a CT?
On the x-ray, it just looked like a pneumonia. Yeah. I don't have it here.
So I guess the point is recurrent pneumonias need
recurrent pneumonias in the same location. And that was the key, is like, when I see a kid in my clinic for recurrent pneumonia, first of all, my first question is it really pneumonia? Because asthma can look like pneumonia to outside radiologists very frequently. And so a lot of kids who see me for recurrent pneumonias end up on asthma medications, because it turns out that they cough when they run around and they cough at nighttime and their illnesses last forever. And then the question is, if they're true pneumonias, are they in the same location, or are they in different locations? If they're in the same location, I think about something anatomic, whether a foreign body or just the way their airways are made. And if it's in different locations, it makes me think more about an immune system problem.
That's a great reminder. Thank you.
My question goes a little bit back to this dilemma of the toddlers who are in daycare, and I'm a hospitalist, so I see that a lot. I feel like, when we're defining chronic cough, I know we've set this duration of 4 weeks. Is that technically supposed to be a daily thing? Like, if you can get a family to pretty clearly be able to be like, oh, they were better for a day or two and then they started coughing again, does that reset the clock? Or how are we defining that 4 weeks duration when it comes to the chronicity? Because I feel like we hear that story pretty frequently of they do get better, but then they get sick again.
Yeah, thank you for that question. That was my lived reality for 14 months. where, they get a cold, they're coughing, the cough isn't completely gone before they get the next one. And so it's nonstop, but it's not like it's the same thing the whole time. And it's interesting to pick that apart with patients and families, and it's also really hard with what you're seeing in the room. And sometimes you can tell, like, this family is just really anxious and the kid looks totally fine. And sometimes the kid doesn't look fine. And so I think there's a huge variety in terms of what you see. But yeah, that sounds like recurrent respiratory infections to me. And I mean, I'm a type A pediatrician mom, and on the one hand, I'm like, I think he aspirates. I think he's got tracheomalacia. Maybe he's got protracted bacterial bronchitis. And then on the other hand, I'm like, you're fine. You're fine. You just go back to school. That's where the germs came from. And that side of me kept winning out. But that is definitely something that I struggled with.
So you did not end up treating Eli?
I did not treat Eli. I actually asked his pediatrician this year. I was like, am I a terrible pediatric pulmonary mom that I've not worried about this? She's like, no, you're fine.
Good job, good job.
She trained here. She's great.
So I think we will end a little bit early today. Thank you so much, Dr. Liptzin. Really, really interesting. And I hope you get your grant funded. Everybody, we'll see you next week.